All right, so this lecture is medical nutrition therapy for genetic and metabolic disorders. So let's talk a little bit about genetic and metabolic disorders. So here we're going to see an absence or reduced activity of a specific enzyme or cofactor. Now most of these disorders are autosomal recessive, and so what this means is both parents have to carry the trait to pass it on. So this is going back to the genomics chapter, so again, if you want to review autosomal recessive. So sometimes with early treatment that's carefully continued throughout life, this allows for a normal physical and cognitive development, and sometimes even careful treatment does not prevent cognitive and physical damage. So newborn screening, and so what we do now in the United States, and this is varied state by state, is that there is a minimum number of diseases that are screened in newborns. So states may increase the number, but they can't decrease below the minimum. So what they do is what's known as a heel stick, and so they literally take literally a couple of drops of blood, and then they use spectroscopy, and so then what we're actually able to do is we're able to determine and check for these errors in metabolism very early on. So again, these illnesses can come on very quickly, several days after life, so we want to check for them extremely soon. Again, this screening is mandatory by law, and so again, what this does is, one, of course, it has its altruistic nature, but also, right, if we're looking at trying to prevent disability in children, so again, the government likes it in that it also helps prevent them having to make payments, right, if there's any disabilities they could have prevented. Again, we're looking at a couple drops. This is not a significant blood draw. So prenatal diagnosis is available, but this usually requires, we have to know somebody's at risk because this is much more expensive testing that we would check for in utero. So it's not part of the routine pregnancy testing. So the goals, right, of medical nutrition therapy is we want to maintain biochemical equilibrium for the affected pathway. We want to provide adequate nutrients to support growth and development and support social and emotional development. So nutrition interventions, so again, circumventing the missing or inactive enzyme. So again, if you're missing the enzyme to break something down, to break down protein, it's actually a specific amino acid, but a protein, well, it's pretty simple treatments. Now, how we implement this can be complicated, but if you can't break down protein X, don't feed the patient protein X, which is restricting the substrate. Don't feed them that food. Or if protein X leads to protein Y, and you cannot eat protein X, then we supplement or give you protein Y. Now let's say the other option is that to go from X to Y requires a special enzyme. Well, we could give you that. We could supplement the enzymatic cofactor. And usually therapies, depending on the specific disease, combine all three of those approaches or two of those three approaches. So amino acid disorders. So again, substrate restriction, limiting one or more essential amino acids to the minimum requirement. Inadequate intake of essential amino acids can be just as detrimental as excess, so we have to then thread the needle, not too much, not too little. We want to supplement the product of specific enzymatic reaction, but, right, so amino acid needs change very frequently, especially in children who are growing very rapidly, so it can be difficult to determine precise requirements for individual amino acids. So with careful and frequent monitoring, our goal is to ensure adequacy for a nutritional prescription without contributing to any complications or side effects. So the most famous example of one of these types of disorders is phenylketonuria, or PKU. So phenylalanine is not able to be metabolized to tyrosine because of a deficiency or inactivity of phenylalanine hydroxylase. So the patient cannot digest phenylalanine, so we restrict phenylalanine. We do not give them phenylalanine. But they still need tyrosine. If you do not have any phenylalanine in your body, you cannot make tyrosine. So I will not give you phenylalanine, and I will give you some extra tyrosine because you don't have that. So this is often found with the newborn blood screening, and so outcome is measured as intelligence quotient attainment. And so again, it's related to compliance and rigorous nutritional therapy. So we want to follow the nutritional therapy as much as possible. So here you can see, again, this is a type of graphic that you might see on a test. And so what you can see here is what's known as the blocks. And so what that means is that wherever you see those blocks or those square tiles, that does not happen. So at reaction 1, you see phenylalanine turns into tyrosine with phenylalanine hydroxylase. You then also see, right, NADPH to NAD plus and bioterin synthetase, right, in this to the 7,8-BH2. So all three of those are blocked in people with hyperphenylalanemia. So the medical nutrition therapy for infants and children. So again, we have a specific, this goes back to our infancy, we have our metabolic formula, so a phenylalanine-free formula that can be supplemented with regular infant formula or breast milk, so again, depending on the patient's needs and sensitivity. So it provides about 90% of the protein and 80% of the energy for infants and toddlers. From there, right, we're going to be looking at low phenylalanine foods. So we still want to support developmental readiness and meet energy needs. But again, what actually may happen is to ensure that we're getting adequate nutrient needs and specifically proteins that are low in phenylalanine, then phenylalanine-free formula will be continued to be used even as the child grows. So guidelines for a low phenylalanine food pattern. So you want to calculate the child's need for phenylalanine, protein, and energy. Estimating the amount of phenylalanine, protein, and energy from foods other than the formula. And again, confirming a reasonable food pattern, right, provided with the estimated phenylalanine food guide. And so what you can examine and what I will show you all during the Zoom session is how we can identify. So remember that phenylalanine is an amino acid. So it's going to be found in foods that contain protein. So of course, lower protein foods will be lower in phenylalanine. And then when you want to examine exact amounts, I can actually show you this can be done on the USDA Food Nutrient Database, where you can actually see the amino acid content of specific foods. So again, our goal for blood phenylalanine is 2 to 6 milligrams per deciliter. Now the problem is this is an essential amino acid, which means it's also incorporated into human tissue. So you'll notice there will be high levels from increased intake or tissue catabolism. So the biggest problem is that when these patients get sick or injured and they're in a catabolic state, the breakdown of their own muscle tissue will increase the levels of phenylalanine, causing an acute exacerbation. So we want to educate the family about therapy management, closely monitoring growth and development. Again, this is an essential amino acid, so we want to make sure that growth isn't affected. And psychosocial development. So again, this therapy is continued into adolescence with an emphasis on self-management skills or making sure the patient is able to identify lower protein foods or phenylalanine-free foods. Again, avoiding sugar-free gum, etc. Right? So the patient can make the choices for themselves without having someone to guide all of their choices. So here we see an example of a phenylketonuria food record, or so a food record for keeping track of phenylalanine containing foods. And so again, the record's fairly simple with just the name of the food, the quantity, and if it follows the guidelines. And again, these skills, right, increase with developmental readiness. And so again, you might have discussed some of this in counseling. But for example, here's a list of tasks to be expected of children. So by age, so by 2 to 3, children should be able to say yes or no to certain foods. By 3 to 4, they should be able to do basic counting. So how much of a food? I had 2 of these to eat, 3 of these to eat. 4 and 5, we can increase and actually measure. 5 to 6, they should be able to prepare their own formula. 6 to 7, basic notes in their food diary. 7 to 8, again, making decisions on after-school snacks, again, because they're able to identify what are the appropriate foods. 8 to 9, preparing breakfast. 9 to 10, packing their own lunches. 10 to 14, managing food choices with increasing independence. And by 14 to 18, they should be able to independently manage their condition. So now we'll talk about BH4, which is tetrahydrobioterin. So BH4 has been researched as an alternative to a severe diet restriction. So you may have recognized this BH4. So going back a couple of slides when we looked at the block, this was one of the 3 enzymatic blocks. So here we have sapropterin, is a synthetic form of BH4, and this can be used as an adjunct therapy in more mild cases of PKU. And so again, because of the level of mutations, right, and differences in genes, there are more mild forms of PKU. So nutritional care in maternal PKU. So high maternal blood levels of phenylalanine damage the fetus. So again, if mom's PKU is uncontrolled, this can damage the fetus. And infants have increased occurrence of cardiac defects, retarded growth, microcephaly, and mental retardation. And it's difficult to keep the levels low, right? So we want to keep the phenylalanine levels low in mom's blood because of the ever-changing needs. This can be difficult to manage and track. So this requires family and professional support with strict management and monitoring. And for adults with PKU, those diagnosed and treated early have less neurological damage. Those with mental retardation may have hyperactivity or self-abuse. And again, we recommend continuing a low phenylalanine diet throughout the life. So we'll move into our second disorder, which is maple syrup urine disease. And I'll give you a hint about the major symptom. Now, this disease is also called branched-chain ketoaciduria. So this is a defect in branched-chain alpha-keto acid dehydrogenase and prevents the metabolism of the branched-chain amino acids. Remember, that's leucine, isoleucine, and valine. By 4 or 5 days of age, the child will exhibit poor feeding, vomiting, lethargy, and periodic hypertonia. And you guessed it, the child will display sweet malty odor from urine and perspiration. And again, this causes acidosis, neurological deterioration, seizures, coma, and death. So here you can see, again, a significant number of blocks in the metabolism of the 3 branched chain amino acids. So again, while the treatment concept is very simple, which is, we'll just give them the enzyme, but you'll notice here with this many blocks, right, is that it's much more complicated than just a single enzyme these patients would need. And again, it would be in whole body tissues to be able to effectively metabolize these proteins. So the MNT for maple syrup urine disease. So branched chain amino acids are introduced gradually after plasma leucine levels decrease. Relapses are common during infection. Early intervention and meticulous biochemical control provide reasonable growth and intellectual development. So again, we try to be as perfect as possible. Special formula is supplemented with a standard infant formula or cow's milk, and may require supplements of valine or isoleucine to balance, right, the total amount of leucine. So here we have some disorders of organic acid metabolism. So this is an accumulation in the blood of non-amino organic acids. For example, propionic acidemia, a defect of propional-CoA carboxylase. So these patients may respond to pharmacological doses of biotin. Survivors often have permanent neurological damage, hypotonia, and cognitive delay, even with early diagnosis and treatment. Methylmalonic acidemia or aciduria, again, at least 5 enzyme deficiencies characterized by acidosis, hypoglycemia, ketonuria, and elevated plasma ammonia and lactate. And these patients may respond to pharmacological doses of B12. So our medical nutrition therapy for disorders of organic acid metabolism, again, maintaining energy and fluid intake to prevent tissue breakdown and dehydration. Relapses of metabolic acidosis from excessive protein intake, infection, constipation, and so on are common. Rapid treatment with illness. So again, these patients are usually hospitalized and monitored. So I'll tell you a little bit at the conclusion of this lecture about my experience with these types of patients. Protein 1 to 1.5 grams per kilogram. And again, a combination of standard and protein-free formulas. We also have ketone utilization disorders. So these are characterized as disorders of isoleucine and ketone body metabolism. Again, usually affects older infants or toddlers. Symptoms include ketoacidosis, vomiting, lethargy, and dehydration. So these are treated with a protein restriction, so 1.5 grams per kilogram. Again, supplemented with L-carnitine and avoid fasting with small frequent meals. as you're not able to handle the ketones that would be generated. And individuals with methylmalonic acidemia may respond again to pharmacological doses of vitamin B12. So disorders of urea cycle metabolism. So here we have ammonia accumulating in the blood with frequent and severe episodes causing neurological damage. And so we have ornithine transcarbamylase deficiency, citrullinemia, arginosuccinic acid urea, and carbamyl phosphate synthetase deficiency. And so out of all these diseases in this whole chapter, I have treated one patient in my life multiple times with citrullinemia. So here you can see again, we can see the block in the enzyme production. So again, as we go from different amino acids. So MNT for urea cycle disorders. So protein free and standard formula. So 1 to 1.5 grams per kilogram per day. Again, complex calculations, it's more being aware that these exist. I don't expect you to be able to do these equations. L-arginine is supplemented, and during acute periods of acute illness, we'll discontinue protein intake and administer IV fluids, and sodium benzoate to lower ammonia levels. Other solutions, we'll talk about protein-restricted diets. So most restrictions are 1 to 2 grams of protein per kilogram per day, which again, remember in the infant population, this is very low. Obviously to an adult, you're going, but this is still high. But remember, in the infants, this is low. Again, individualized calculations, tables of foods and special low protein foods and specialty formulas are all common treatment modes in these patients following these regimens. So galactosemia, so galactose not converted to glucose, and galactose 1-phosphate accumulates. So here we have two disorders. We have galactokinase deficiency and galactose 1-phosphate uridyl transferase or GALT deficiency. Symptoms in the first 2 weeks of life include vomiting, diarrhea, lethargy, failure to thrive, jaundice, hepatomegaly, cataracts, hypoglycemia, and infection. Early diagnosis and treatment lead to normal physical and motor development, but intellectual achievement may be low. So here you can see, again, that block and why galactose 1-phosphate accumulates. So the medical nutrition therapy for galactosemia, lifelong galactose restriction. Galactose is required for the production of galactolipids and cerebrosides, but can be produced via an alternative pathway. So avoid all milk products and lactose-containing products. These infants will receive soy-based formula. Restricting fruits and vegetables that contain galactose, including dates, papayas, bell peppers, persimmons, tomatoes, and watermelons. Again, with normal metabolism, you would almost never even realize there's galactose there, but for these patients, it does make a difference. And checking labels of food and medication for added lactose. So like I said, the biggest offender is things like salt and vinegar chips, where lactose is used to bind the flavor, but it has nothing to actually do with the product itself. Glycogen storage disease, inability to metabolize glycogen to glucose, leading to poor physical growth, hypoglycemia, hepatomegaly, and abnormal biochemistry. This is a whole family of disorders, but GSD1A and GSD3 are the most common variants. So we need to provide a constant supply of exogenous glucose to prevent hypoglycemia. And so raw cornstarch at regular intervals and high complex carbohydrate, low-fat dietary pattern. Young infants may require pancreatic enzymes to digest the added amounts of carbohydrates. Some require glucose polymers via a continuous drip gastric feeding at night to maintain blood glucose, and iron supplementation. Disorders of fatty acid oxidation. So we have things like medium chain acyl-CoA dehydrogenase deficiency or MCAD, and long chain 3-hydroxyacyl-CoA dehydrogenase deficiency or LCHAD. So hypoglycemia and abnormal liver function, reduced or absent ketones in the urine, and secondary carnitine deficiency. So avoid fasting with regularly spaced meals, high in carbs, and less than 30% energy as fat, and L-carnitine supplements may be required. And here you can see where the block occurs. So here we have some focal points just to kind of summarize it. But again, so I know it's a lot of different diseases and a lot of acronyms. And in essence, these patients are incredibly rare. and usually if they are going to be seen, right, they're going to go to their care providers who have been following them for many, many years. So I can tell you I have treated one patient, and that was for citrullinemia. So they had a problem with citrulline. And so again, whenever they would get sick, it would increase the amount of citrulline in their blood. They would then have neurological symptoms, and they would come to our facility. Now, we actually kept a specific case of their specific metabolic formula because unfortunately, they would come in probably about every 6 to 8 weeks because again, what would normally be a cold for you and I causes enough catabolism in them that it does trigger an event, an acute attack. And again, most of what we did was providing the formula, providing fluids, and kind of letting blood levels return to normal. A lot of it is supportive care. The rest of it is really education and avoiding foods, which usually families and patients are pretty good at once they've gone through the initial training of if you go to eat something, you check the list. If it's on the list, don't eat it. Now, when it comes to testing purposes, you can see based on the amount of slides that it took up within the chapter, I want you to focus on basically things that have the big nutrition implications or are most common. So the heavy hitters, the frequently asked questions are going to be PKU, maple syrup urine disease, glycogen storage disease, and galactosemia. So those four. So issues with phenylalanine, issues with the branch chains, issues with galactose, and issues with glycogen. The organic acids, the super rare variants, there's 4 different acronyms. That's good to know, but I understand that people have limited study time. So those are the 4 I want you to know for our purposes. And again, those will be the ones you'd be most likely to encounter in real life and on the RD exam. Thank you so much, and I look forward to your questions in our discussion.